Special thank you to our advertisers, Alsana. Alsana has both physical locations in Alabama and California, and then virtual IOP. They also have an IOP specialized for teenagers, which is really, really cool as well.
Hi. Hello. How's it going?
I'm doing well. How are you?
Good.
Wow. Thanks for being here.
Yes, I'm really excited. Thanks for having me.
I can't believe that we had the opportunity to meet in the way that we did.
So cool. And I love that we're already able to do something like this. I know when we first met, we were already talking about like research opportunities or any way we could progress together. So I think it's really cool we're able to do this so soon.
What brought you into this field?
So I got into this community because I'm actually recovered myself from an eating disorder. So I grew up in the gymnastics world. That is where eating disorders tend to be not only glamorized, but maybe even encouraged. So I really just saw a need within the community. And I had this unrelenting belief that this is kind of what I was meant to do now that I'm in that recovered space. And ever since then, I've never looked back.
I remember the first time you shared that story with me, I got chills and I got it again. That's such a special story. And like coming from the dance community, it totally was glamorized and encouraged. And then you were rewarded even in those spaces.
Absolutely. You know, comments about, she'll be a great gymnast. She's thin. All of those things for somebody with a predisposition for an eating disorder, it can have an impact people don't realize. And exactly in the dance world as well, you're staring in mirrors all day. Your body shape is actually being critiqued. Your size, your lines, right? There was almost like you'll hear those things of like, get your butt under, get your ribs in. And if you think about it, if you have to get your ribs in, what about things of like breasts or, womanly features and things of that nature? So it's certainly something that, in the social world, but as well as in that sort of sport world as well.
Yeah. We were told to like lose our summer and like only eat certain things.
Lose our summer. That's a new one for me.
Yeah. That was, we came back. It was maybe our like junior year of high school and it was like we enjoyed our summer break and right. We're told to lose our summer.
And, all these things that we're talking about, I'm going to make an assumption with you too, but this was during like formative years. Our brains are growing and adjusting and we're hearing these things at a pretty intense level. I think people don't know how damaging certain sentences like that can be. Yeah. The lose your summer, the I can see your lunch. There's so many one-liners. I feel like that you can throw out there thin to win that's part of the reason, right? That one. So that's, yeah. And that right there is part of the reason that we do this, right? Because we know the impact that 3 words can have on somebody's livelihood and life, honestly.
Yeah. Oh gosh. Every time I speak with you, I just get so overcome with appreciation for doing this work with you and having you as a support because it's hard stuff that we do as therapists in this community. Knowing that there's only 0.01 like of all therapists, 0.01 are eating disorder specialists. So there's not many of us and knowing that I have you as a support is just really like monumental for me.
That 0.01% is like important for people to hear. Yeah. Cause I think people think that, if you need help, it's accessible and it's a huge challenge. And so that's why I'm so glad that I found somebody that I can grow with and learn with and we challenge one another. And, our backgrounds coming with different trainings and things of that nature. Yeah. There are certain nuances that you have been able to share with me that have been so invaluable to my work. Yeah. So that's been something I've really cherished.
You make such a good point with the access to care. So depending on where you are in the country, when I was an intern at the National Eating Disorders Association, I would help people find providers who specialize in this. And we would get calls from rural Alabama and I would be searching and I'd be like, there is no eating disorder specialist within 150 miles of you. So, this was pre-COVID. So COVID and telehealth has absolutely opened up the accessibility of different providers.
Absolutely.
But what were people to do? And in-person work, especially with eating disorders, is so important. So it's heartbreaking that there aren't as many of us in this world. So my hope is that through doing things like this, like a documentary, we can inspire people to help this community.
And I think the reason too why there's that 0.01 is there's a lack of awareness maybe of the prevalence of eating disorders and how common they are. But I also think the lack of training, for specialized care is something that is just a huge challenge because obviously both of us sought out, extra supervision, extra education. We really grew in our craft and it took a lot of time and dedication to get where we are. And we're going to have to keep growing every day. And I think if we could have some training off the bat, maybe not just a chapter in school, right? If we could have somebody, a specialist come in and discuss these nuances, maybe even spark interest for somebody that feels like they could help this population, that'd be a change that I would just love to see. Yeah. So if someday we could look at that 0.01 and be like, whoa, we really lived that. That'd be a really cool change.
I would love to hear what your training experiences were like, because you're right. It was incredibly hard to find any supervisor or training program that was accepting students. Right. And even taking classes on it, there was such an absence of that.
So something that was actually interesting for me is that I did my master's in clinical mental health counseling, but that was just for general, right? So that is so that we can, treat clinically, technically anybody that walks into our office. But I knew very early on I wanted to work with eating disorders. So while in school, I actually, already sought out like CEUs, continuing education units on my own. Of course you did. So I would reach out, to different CEUs and explain to them, I couldn't really even afford much back then. So I was like, hey, I'm a student. Like, I'm not actually seeking credit. I just want to learn. And I will say I was really well received with those questions. So I got to do that. I had a wonderful mentor that helped connect me with, the SEDS credential. So, certified eating disorder specialist, kind of how to get on that track. And I actually first started paying and working with a SED supervisor while I was still in my master's.
Wow.
So it was something that I knew I'm going to need some more insight. I'm going to need some more education here. But I had to seek that out on my own, and luckily I had a wonderful mentor to help guide me. But outside of that, it was really just kind of living and learning. Right. And so from there, it's just, seeking extra consultation and things of that nature. I pull a little bit of what I do from my own experience, not in the sense of thinking that my clients lived the same life or anything of that nature, but certain nuances that I can recall might spark a question, right? Hey, is this, what do you think about this thought? And sometimes what's been really interesting is they'll be like, nobody's asked me that question before. Yeah. And that's always a really cool moment. But talk to me about your training. I know that you did a stint at a treatment center and all of that.
Yeah. Awesome. Yeah. And just what you said inspired so many questions. But, I'm gonna have to keep them stored. So I also always knew that I wanted to work with eating disorders. By the time I was a junior in high school, I knew that I wanted to do my PsyD and go this route. So I majored in psychology and minored in dance and human service studies in college. And again, no eating disorder information there. And then my undergrad university provided an eating disorder treatment diagnosis and conceptualization class. So we had this thing called J term where I went to undergrad, and it was the month of January. You took one class, and we had a treatment provider from Eating Recovery Center come to our university and teach this amazing class. And she and I clicked, and she just kind of gave me tools and resources and a platform to understand eating disorders and then also be an advocate for the community. From then, I worked at the National Eating Disorders Association for 6 months. I interned there in New York City, which was really cool, and I was working on the hotline. And after that, these things just started coming to me, which I feel like when you put it out in the universe, it ends up coming to you.
Yes.
Then I met someone who was doing research in the field, and he's also still in contact with me. He's my mentor. My partner and I actually visited him last year. And we did research on the correlation between eating disorders and perfectionism in college-age women, specifically anorexia, wow. Which was really, really rewarding, and no shocker, there was a positive correlation. Yeah. And then from there, I applied to grad school. And oddly enough, in grad school is where I had more difficulty getting access to eating disorder education. We did offer a specialized class, but it was an elective, and I didn't have space in my schedule to take it. So I was so frustrated that I couldn't get an eating disorder class at an advanced level. So I did everything that was adjacent to eating disorders. I did substance use, I did trauma, motivational interviewing, you name it, I did it if it was eating disorders adjacent. And then I had my mentor in grad school. She also specialized in eating disorders and again opened my world up to so many different opportunities. And then I was a practicum student at the Renfrew Center. And I loved working at higher level of care, and I learned so much at that level. And then I did my pre-doc internship at the University of California, Davis in their eating disorder emphasis area. So I've worked with eating disorders on all different levels, and I've worked with someone who it was the first time even labeling their experience as an eating disorder, all the way to someone who is in recovery after 15 years of suffering, and they're like, I didn't even think about my body in that experience. And having that breadth of treatment and watching my clients evolve from those spots has been so rewarding.
Absolutely. And yeah, when you said there, you know, somebody being like, I didn't even think about it that much. Those are some of those moments that those can make your whole day, right? Typically I don't know if you've ever sort of asked this question of what percent of your day are you thinking of food and body? And I don't think people realize, if they're outside of this eating disorder world, it is incredibly common for people to answer upwards of 95% of their day. Yeah. Close to 100, I've heard as well. So that leaves 5% to be a friend, a family member, maybe go to work, maybe be a student, maybe enjoy a hobby. So that is just something too, that when you start to see that percentage come down and start to swing more in their favor, and you start to learn more things about them as a human and less about just their clinical eating disorder. Yeah. That's one of those really cool moments. And yeah, like you said, there are some people, they might come in and it's day one. They've never addressed this. And that's a really powerful moment, because that's such a vulnerable space to be in, because, you know, life can change once you have that acceptance. So, but then there are people too that'll come in and, man, they've lived with it so long, and they might even be losing hope. And I think that's kind of one of the biggest challenges that I think, at least in my realm, from a clinical perspective, is when people start to lose that light at the end of the tunnel. You know, I always say, if people knew that they'd recover from an eating disorder, this disorder would not be so deadly, because everybody would have a reason to fight. And I think one of the biggest challenges is when people no longer think or believe that what they're fighting for is possible for them. Those are kind of one of the biggest challenges that I see. But then on the flip side of that, when you see a glimmer of hope in somebody's eye, it's a delicate balance there. But what are some challenges that you see in this field?
Oh, I was going to ask you that. So for me, I noticed that a common countertransference I have is like being protective, and like maybe sometimes wanting more for the client than they want for themselves. Yeah. So it's a hard balance to hold, where you want to instill hope and be the hope for your clients, while also meeting them where they're at and not being like too overzealous of what life could look like, because we still have to recognize the eating disorder was incredibly functional. And sometimes within my own work, I can get ahead of myself and be like, look at this world you can have without your eating disorder. And there's an abundance of life that you can have. You can be an amazing mother, you can be an amazing brother, like classmate. Like there's so many different facets of your identity that we can tap into. And I think I get a little too excited. And I what's challenging for me is to honor the eating disorder. And I think, and I would love to hear about our different perspectives as you're a provider in recovery, and I'm fortunate to not have experienced it, of how that might impact our work. Right. But that is my biggest challenge in this work.
Well, let's just say, when you said that, I heavily related, because you will be able to see all these wonderful things that are in their life, and you can see, you know, everything they can't, right? And so an analogy I always use is kind of like a butterfly doesn't know what its wings look like. And so you'd have to explain to a butterfly like how gorgeous they are and the colors, and they can choose to believe you or not. And I can also get caught up in like, no, but look at your wings. Yeah. But they're like, but I can't see it. So I definitely related to that. And I appreciate our candidness of talking about the challenges with this work and boundaries. As far as being a recovered clinician, I've actually had an opposite reaction to what I thought I would. So when I first started, I really worried, you know, could I ever start to get maybe heavily identify with somebody, or maybe overly identify with their story. What I've actually found, which is both a blessing and a shock, is that I've had to intentionally try to reconnect with my old self. Wow. And it's something I never, you know, it's just crazy to say now. But I have to really, there are times I even have to reel it back and be like, Maria, let's remember how challenging this was. You know, these decisions or these interventions or homework assignments we give, these are earth-shattering moments, you know, like that brain and amygdala is screaming, no, stop, right? Yeah. So that's actually been my experience. And I don't know if other recovered clinicians can relate to that or not, but it was certainly a shocking one for me. So there's definitely that compassion. Sometimes when clients will say a certain thing, I guess my own sort of countertransference is when my brain goes, man, I said it too though, right? Aww, yeah. And that's always hard when they're like, you don't understand. I assume you've heard the sentence before, I'm different. I'm not going to recover. It's not possible. And I remember saying that with my whole chest. Yeah. You know, I just believed wholeheartedly that life wasn't possible for me. And now here I am intentionally trying to reconnect with it. I think that's where I can get ahead of myself too, because there's all that hope that I'm like, no, this is your eating disorder that wants you to believe this. But that has been my experience. It's also just been incredibly rewarding. That's something that was so painful, morphed into a passion that's now a profession.
Yeah.
I just think that that's been an awesome thing to navigate.
And that's exactly the inspiration that brought me to this field. And while yours is intrapersonal, mine is across generations. And seeing how healed you are from this, like you are the epitome that recovery is possible. And I could tear.
Yes. Yeah.
With my situation, what got me passionate into this field was the generational aspect of it, because in a lot of senses it is passed down, whether it is within your family or even socially and within the cultural context. And I think because I'm not a recovered clinician, I think I see it from a more voyeuristic lens, and it allows me to have a curiosity about it. And also, I think sometimes I do lack that ability to turn inward. That being said, every person has a body. Every person has lived in a world where thin privilege is real. So I try to tap into that part of myself.
Well, and you've lived certain nuances that I can't relate to, right? There were things that I could see, maybe how it was hurting my family or how it was harming my friends or that sort of pain. But you were the one kind of living with that, right? And maybe feeling helpless or something to be able to help some loved ones. But the way you guys were able to just stop that chain from continuing, I think is just super empowering. And I hope that we can continue to explore what dynamics were taking place that allowed that to happen. You talked about thin privilege. I would say another huge challenge here is it's kind of us against the world.
Oh my gosh, yes.
Right. And I know that sounds kind of dramatic, but to an extent, our clients might have 50 minutes with us a week, maybe more, maybe less in some circumstances, right? They could leave our office and they could hear on the radio an ad for, lose weight quick. Then they could walk into the store and there's a scale and there's, a measurement tape. There's a diet pill. That's what they're around for the majority of their life. And for 50 minutes, we try to centralize in anything else that's important, not your food and body. But I think that's one of the really toughest things here is this profession it's not in line with a multi-billion-dollar industry of beauty and thinness and health. And I think that's been a real challenge for me in my work.
Wow. That is a hill I will die on.
Yes. Yes, absolutely.
And you're so right. We have in the treatment modality you and I give, we have 50 minutes of a week. And there's so many other things that go on in the world that might perpetuate the eating disorder. I was parking the other day and I was on Park Mobile and I got an Ozempic ad.
Wow.
It is pervasive. Have you ever heard of the cave and the canary analogy?
I have not.
Okay, I learned about it while I was on internship. Back in the coal mining days, coal miners would bring a canary into the cave, and the canary would be able to perceive when poison was in the air before humans could feel it. So they would bring the canary into the cave. When the canary would die, they would say, oh, okay, this is where we stop, and this is where it's no longer safe. What we say is that folks with eating disorders are the canaries, right? Because they have such an attunement to their social experiences, and we know that individuals with eating disorders have a heightened social acuity. So the fact that the canary died as a consequence of the environment is a representation of the eating disorder, yes. Because folks with eating disorders are so much more sensitive and more attuned to their environment, so they're going to be absorbing these things, which is why we as a society have such a responsibility to take care of those people because of that sensitivity and how attuned they are to that experience.
And you bring up a really good point with the sensitivity and the way that you could sit 5 individuals in a room, tell them all the same sentence. One person might laugh it off. One person might be like, that was kind of mean. One person might be like, I agree. And 2 might remember it for the rest of their life. And so, yeah, that hypersensitivity and that social acuity of what is going on around them, it's being received in a different way. And I think that's a lot of where the misconceptions come from. People will be like, well, everybody talks about body, right? And I'm like, but you don't have the predisposition for a switch to go off in your brain. And that's just something that's huge too, right? And maybe they're like, they're overly sensitive. I'm like, absolutely. Yeah. Their body, their nervous system is overly sensitive from whatever experiences have happened in their life due to hereditary reasons. I hear this a lot. I don't know if you do, but like, are they doing this for attention? Man, and my question back to them is always, and if they are, what does that say?
Right.
If they are willing to bring themselves, either starve themselves, harm themselves, use certain behaviors that are just so incredibly painful to our psyche to get your attention, I think that's the question we need to be asking is what is causing that? So that's another one that I know that we hear a lot in the field that I definitely wanted to almost clarify there.
Yes, the attention piece, or that it's about an aesthetic. No, like the majority of the time this is about control.
Yes.
And it is a metaphor for other things going on in the life. So oftentimes what we take into our body or the way we present our body it's a way to communicate. And when we don't have the words to share what we're feeling, maybe we show it through our behaviors. And the eating disorder is exactly that.
Right. That's probably one of the strongest mechanisms I see is I don't want to ask for help. So I show them that I need it because then I don't have to ask for it. Right. So, but that's a dangerous trap too, right? Because only 6% of individuals with an eating disorder are clinically underweight.
Yes.
And I almost want to repeat that sentence. That
Let's do it again.
Yeah,
say it again.
Only 6% of individuals with an eating disorder are clinically underweight. So that means 94% are at or above a weight range, right? The amount of misdiagnoses or just going completely undetected, it's just so sad. So sure, 6% might be able to illustrate through their body, I'm hurting, please help me. And they don't have to use their words. And I assume in your work too, that's something we work on is how can we use our words and verbalize needs. But 94% often then report feeling so invalidated because they're like, look at me, I'm screaming for help. And everybody says, you look great. Did you lose some weight?
Yeah.
And that's just so hard. I'm like, well, you just complimented the most challenging thing that's happening in their life that's eating them apart. So that'd be another change I want to see in the field. I don't know if this is a controversial one, but I'll say it anyways.
Do it.
The term atypical anorexia, if there is one change I want to be seeing, I want it to be that diagnosis.
Yes.
How can something be atypical
when it's the norm?
The most common presentation. And what you basically tell your client who already thinks they're not sick enough, already thinks they didn't lose enough weight. You said, you're right.
You're great.
You're actually atypical.
Yeah.
So that's horrible, right? So that is something that clearly I try to even mince in my own language. Or if for some reason that diagnosis does need to be brought up, truly explaining circumstances there. But man, I just believe that's doing a lot of harm. A common mechanism is I'm not sick enough. And you said you didn't meet criteria, actually.
So actually, you're right.
And then what do?
They get sicker.
They attempt to meet criteria. Some might end up meeting them, but what would have happened if we took them seriously?
Right.
What would have happened if we said, instead of saying, congrats on your weight loss, if we said, is everything going on okay with food and body? What are some other changes that you kind of hope to see in the field?
The BMI.
Oh my goodness. I got a body reaction to that.
So the fact that we have to use the BMI as a criteria set to be diagnosed, the fact that a lot of insurance agencies use the BMI. When I was working at Renfrew, I saw a person who was an average BMI. They were in a feeding tube because they were so malnourished. And I think that is a common misconception that you can be living in a body that is societally acceptable and still be incredibly ill. So whenever I'm teaching about eating disorders or training on eating disorders, yes, it is so important to honor the DSM and be using evidence-based care. And these are the ways that the eating disorder criteria set is incredibly discriminatory.
Right. Absolutely. And that's the fine line that we walk, right? Like we need to be using, evidence-based practices and yes, using that DSM in the way that it was created to be used. But I don't know about you, but I get this little twinge in my heart whenever that's something that has to be reported. And when people ask why.
Right.
You're going to look somebody in the face with the eating disorder and say, you weigh too much?
Right.
It's horrible. And so I just wonder if when someday that is reassessed again, if we can look at that mechanism, right? And see if there's any other way that we can approach that matter.
Yeah, really, really important. So when I'm training individuals to work with eating disorders, I say, yes, their phenotype is important. The way they look is important. We're not going to discredit that because it can sometimes indicate severity. And we want to be looking at behaviors. Assessing behaviors is the most important thing. So I had a trainee who was incredibly skilled, and a client came in for binge eating, and they were living in a larger body, and I asked, did you assess for restriction? And she said, no. I said, did you assess for purging? And she said, no. And granted, so developmentally appropriate. She's an amazing trainee, and I think that just shows how we need more training on eating disorders, and how your own internalized weight stigma in this trainee's mind, this person was living in a larger body. How could she be restricting? So I was like, go back, do the assessment. I guarantee you there's something else going on.
Let's see what comes up here.
And the client was restricting pretty significantly, and she was in that binge restrict cycle. And just when she came to treatment, she was in the binge cycle. And oftentimes, especially with folks who live in a larger body or do have binge presentations, they see the binge as the problematic behavior and the restriction as the good behavior. So they're not, so I say, hey, we can't have one without the other. Right. So if you want to eliminate the binging, we have to take on the restriction too. I really find it so important that when you are working with this community, you assess for all different types of eating disorders.
Absolutely. And what you just described is how so many go undetected, right? And I can hear where that clinician came from, but we, of course, it's sending off alarm bells, right? But that's the difference in the nuances that we know to pick up on, that I will always assess for anything, right? The other thing though here is assessing for behaviors that aren't so glamorous. So unfortunately in the eating disorder world, and this is, it's not something I agree with. I need it to be known, but it's the way eating disorders perceive one another. It's right. There's restriction in first place.
That's
right. That's on first place. And the way I describe it is you're usually too weak to stand up to receive your trophy. Right.
Oh my gosh, Maria.
Right.
Wow.
But there you go. You got your first place, your badge of honor. But then your anosognosia or your inability to see your sickness, you don't know you got your badge.
Yeah.
Right. And then again, I don't believe with this hierarchy, but
it's real.
Next there's those like the purging and the laxatives, right? And how sad that the competitive nature within eating disorders is like, really? You had to purge? And those are the nuances that I don't think other people understand, is the competitive edge is there, right? And then the binging, right? It's binging, bad, restriction, good. Yeah. So I've even heard of, I've received clients that worked with different providers. They prescribed restriction interventions to combat binging.
Yes.
Because they view it as like, that one's like lower, right? So this is harm reduction to work on restriction or to actually engage with it. And it's like, oh my goodness, it's the same coin flipped, right? But that's a nuance too that you always want to assess with your clients, is that competitive nature. I would argue, say most of my clients feel as if they're in second place.
Yeah.
Right? Somebody got sicker than them. There's some bar they didn't reach. And that's another nuance, that a lot of disorders, people want to recover. Yeah. Right? Some people really do want to recover from their eating disorder, right? And also some people want to get as sick as they can. And that's twisted in the way that a lot of other even clinicians not in this field wouldn't be used to clients that engage with that sort of mechanism. But, putting badges of honor on, feeding tubes, on, length of hospital stays, the amount of admissions.
Yes.
To somebody with an eating disorder, that's highly competitive, right? So those sort of things are something that I try to steer away from, with my clients in a group setting.
Yes.
As well as, we always say no numbers talk, right? And I think that's important for families to hear, is no numbers, please, right? We're not talking about weight. We're not talking about calories. We're not talking about, amounts of times we've engaged with certain behaviors. All those numbers, most of them could repeat them back for quite some time.
You bring up such an important point. There's a lot of research that says healing from an eating disorder does incredible work in a group setting. And I think as healing as it can be is as damaging as it can be.
Agreed, 100%.
If you don't have the proper facilitator. So that's why eating disorder groups need to be done by someone who knows what they're doing.
Absolutely.
You have to know the boundaries, you have to know the language, you have to know what's safe, what's not safe, how to talk about these things, because if done wrong, it can be incredibly reckless. So that's why I believe if you have an eating disorder, you need to be working with a specialist. You need to be working with someone who knows this pathology. And personally, if I'm looking for referrals for someone, if I'm on Psychology Today and I see they specialize in weight loss, I will not refer to them. Because how are you body informed and how are you eating disorder informed if you also specialize in weight loss?
I'm so glad you brought that up, because I pull from like a health at every size approach, right? And so regardless of your body type, I'm going to assess you the exact same way as I will the next client behind you, right? But I will see that a lot. Treats eating disorders and also treats, or treats obesity.
Oh, yeah.
That's the word that I probably hear the most, and I will never make that referral, and that's nothing against those clinicians. However, to an extent, if that quote unquote obese client by the BMI scale I disagree with, but if they walk in, you're going to treat their obesity?
Right.
No, we need to work on the eating disorder. We need to work on any habits that got them there. What if they show up and they are fine with their body? They're not presenting to lose weight. Yes. They're like, I exist in a larger body and I love myself.
I'm good. Yeah.
So that, I'm really glad you bring that up though, because that's something too that I don't think people understand. They're like, well, what if they want to lose weight? And what I always say too, when I have clients that they want to lose weight, I always say this: you cannot simultaneously recover from an eating disorder while intentionally trying to change your body weight or shape. Mm-hmm. It doesn't mean your body weight or shape won't change, but if we make it the primary goal, we're not going to land where we'd like to. And that's been a challenge I've noticed, because people even say, well, my other provider, and I kind of say, look, maybe if we work on, hey, can I, feel more energy in my life? Or maybe can I feel more positive in my body? Can I have less pain? Can we focus on having more control or even engagement with food in a positive way? That body might change, but we can't make it be the emphasis, right? Weight restoration is obviously different when we're going up.
Totally.
And a lot of people don't know that we need that, because we've got to have enough glucose and energy in that brain to be able to do a lot of the cognitive work that we do.
Yeah, there's a very interesting dichotomy. I try it with my clients. I try not to moralize weight gain or weight loss. Yes. We encourage intuitive eating. And if there is a weight change, so be it. But that was not the intention.
Right. Exactly.
And whether it was weight gain or weight loss, we're healing our body through engaging in healthy behaviors. Right. And whatever happens, happens.
Yeah. And those are some actually the good language to look for. If you're looking for a referring provider, so they engage with language like intuitive eating, mindfulness-based practices, health at every size, looking for that eating disorder true specialty, not I have an interest in. Right. Those are some of the things that I always want to recommend to other clinicians just to look for, because it shows the framework they're going to pull from.
I was thinking of when we did our training together, one of the presenters shared that when he went to the doctor for a broken wrist, they weighed him. He was like, why do I need to be weighed when I have a broken wrist? Like that my weight has nothing to do with my treatment here. And I believe he was a medical doctor, so he knew. Mm-hmm. And cause sometimes with us, like we don't have that training, so we have to refer out and ask for within our scope. And, I found that so illuminating. And when I used to run a group with eating disorders, we had a whole conversation of ways that you can advocate for yourself within your medical community. So blind weights, huge. Yes. So talking to your providers, it's hard to disclose that you have an eating disorder. And these are some ways that you can help support yourself so you don't get activated or triggered.
Right. And the things like blind weights, though, I've had the experience where I'll work with my client on how do we communicate it, and they'll be really proud of themselves because they'll be like, look, just for the benefit of myself, I'm going to turn around, right? Or maybe they'll just step on. And then they'll say the number out loud.
Yes.
Or they'll be like, wow, you lost some weight. And I'm like, oh my goodness. So that's what's really bad, is that people, it's not intentional, but they are causing harm because that client, it took everything in them to say, I actually don't want to know my weight. Or then they give you your discharge paperwork. Right. So you show up, for that wrist, and you're challenging your eating disorder, right? And you've maybe been on blind weights for quite some time. What is right there in bold? Your BMI. Why? Yeah. Why isn't the prescription for what you should do with your wrist in bold? Yeah. But the BMI always is. And I find that to be a challenge, and I hope that there can be more weight-inclusive care, but also just truly awareness into how this language impacts people, because I don't believe they know. I've seen plenty of eating disorders actually derive from a physician or other professional telling them they need to lose weight when it was never their goal when they walked into that office, and you can fall into a trap. For some people that might be beneficial, sure, right? If they want to align with that, man, can it cause a lot of harm. And so that's another part of this where we're against the world, right? It's, everybody else is like, great work on the weight loss. And I'm like, oh my goodness. Or they're family members will maybe say, oh, you look so healthy when people start to recover. And this is stuff people just don't know. The brain hears fat, right? The brain hears healthy, bad. Right. That's a nuance that, again, family members would just be like, but they don't look like they used to. I'm so proud of them. I'm like, right, but compliment. Your eyes are so much brighter now. I love hearing your laugh so full again. You were so present at dinner. I love having you around at family gatherings. But that's, I think, another trap too, that education is so important. And I'd love to see more progression on education. But again, resources for families. Mm-hmm. It's hard enough to find resources for the clients. Right. But if we could have more resources for families, because man, we could work all day, in a session or in a group, and they can go home and somebody's like, I can tell you're putting on weight. And It's really hard. So people will get frustrated in families because they don't know how to help and they feel like they're walking on eggshells. And I almost answer, you are.
Yeah.
And maybe that can be validating too, that this is not fun for everybody involved, right? Yeah. But that's where that sort of managed care, collaborative care is so important. Family-based, specifically with kids. The family's got to be involved to make sure that the prognosis and longevity of recovery can be the best it can be.
As being an eating disorder provider, we have to be in collaborative care because there are so many aspects of, and you are so much more informed with the medical stuff than I am. I'm telling Maria, what do I do here? Because you're so educated, and I really admire you for the medical quality of the care that you give to your clients. But we have to be constantly working with dietitians, PCPs, psychiatrists, because there's such a scope that the eating disorder damages and then heals from. So we need to learn what are the indicators of recovery and of relapses. So working together in a team. So I spend like an hour a week just like, hey, like just to have collaborative care to make sure that my clients are being taken care of. Yes. And it also leads to burnout, which is why we have to be taking care of ourselves.
Yes. And, I think that treatment team mentality is something too that us specialists just know right off the bat. Okay, right? If we're working on the cognitive and psychological side, I need somebody working on that nutritional aspect.
Right.
As we do that, a lot of people don't even know there's risks associated with eating more after a sustained amount of time with restriction. These days there's been a lot of advancements. I know we were in the same lecture about some medical changes that, some progressions that have helped, but refeeding syndrome, especially in the past, could be very deadly and fatal, right? And so that's another nuance that if a provider is trying to wear all the hats and be, the psychological help, the nutritional help, and the physical help, we're setting ourselves up for a lot of danger.
Right.
So I think that's the understanding too, is we have a certain level of understanding of, nutritional needs as well as physiological consequences, but it's not in our scope of practice to be recommending a meal plan to somebody.
Yeah.
And that's another thing that I've heard when a client will come to me, they're like, oh, well, my old person would just, we'd work on this. And there's this delicate balance, right? But that physiological component we cannot ignore because we cannot see the severity of the eating disorder. Like you said earlier, sometimes we can, that phenotype can show us something, and also sometimes it doesn't. Yeah. So like you said, there could be people in bodies that you would never quote unquote suspect. I hate even encouraging that language.
Right.
But every movie I can think of that has to do with eating disorders, yet we can picture the exact client they have on the screen. One, it's a white female.
Oh, yes.
White female. And they look completely gaunt, completely emaciated. Oh man, that just hurts, right? So that's another change. It's like, I'm so glad that we're even getting together to do this so that we can share these nuances, because someday I hope that somebody watches this and then they check in on their kid instead of being like, great work on the weight loss. They're like, hey, how are we feeling with food?
What you bring up is kind of a future goal I have for the field. So you are right. A lot of the providers in this field are white, cisgendered, thin women.
Yes.
And that is likely because that is what is being represented as an eating disorder. Even the DSM caters towards white, cisgendered women. So if we can, one, diversify our treatment samples so we can learn what an eating disorder looks like amongst more populations, that would be enormous. And then two, if we started to have more treatment providers who were interested in doing this work that came from intersecting identities and various presentations, I really feel that more people would know it's time to get help because they'd be represented in the treatment providers.
Absolutely. Representation is so important, and you're right, because we are so lacking in that area, and it's really sad, honestly, right? But I think too, I don't know if you've heard this before, but I've heard other clinical colleagues almost fear what I do.
Oh my gosh. Terrifying.
Right. They are
won't touch eating disorders.
Yes.
Which I kind of love because know your scope.
Yes. I'm like, please don't touch it if you're not specialized, so I appreciate it. And also to be clinically fearful of diagnoses. That to me just shows a overwhelming lack of insight, education, awareness, and support. Mm-hmm. So you even talked about, burnout. That is something too that I can see in the field. I don't know about you, but it's not uncommon to still be exchanging emails pretty darn late in the day, right?
Gosh, yes.
But those boundaries are so important. I think, especially in this realm of care, we need to be really, really careful with our boundaries. And sometimes that can be a challenge. I know both of us, with that sort of counter transfer. It's like, I want to help and give my all.
Yeah.
But we've got to remember, if we take care of ourselves, we're going to take care of the longevity of our clients. We're going to better help them if we can take care of ourselves. But I think that's a fear that I've noticed with other clinicians. They'll be like, how do you do that? And I typically answer, I love it and it's very rewarding. And yes, it's challenging, but man, where was that education for that clinician? What if that could have sparked an interest? And especially if they're in that more of inclusive populations that's so needed, we missed that opportunity, right? Not only that, but we are misdiagnosing, or disorders are going undetected in different races, genders, things of that nature. Yeah. Because who are we assessing? The white cisgendered women, right? Yeah. That's really, really tough to acknowledge. So there's so many of these changes that I hope that people can grab onto, because a lot of us know it, right? If you set us all in a group with a lot of eating disorder specialists, we could probably talk all day
about this. Yeah.
Yes, but it's like the rest of the world, there's this giant disconnect, right? And that's why I've been so grateful for our, professional relationship, just because it is isolating in a sense, to do the days that we do and have people not really fully understand family, friends, other colleagues, and things of that nature. But that's why I think connection is so important. Having a consultation group, right? Collaborating on cases, all of those things are so important and can't be overlooked.
Our work has a lot of risk factors, as we've really talked about over the last couple of minutes. What would you say common risk factors you see?
I'm starting to see this presentation pretty common around that, starting puberty and things of that nature. It's almost like people are trying to fight that battle, right? Or their bodies are changing and maybe everything else is changing in their life. And what can I stall? What can I control? My body, weight, and shape, right? And so I hope people know, people think like, oh, that doesn't happen in kids. And I'm like, no, the onset is getting earlier and earlier. And I think that's important to note. But specifically with my background, I did D1 gymnastics and things of that nature. We need to be assessing whether kids or adults that are in aesthetic sports and other sports as well. I see a lot of things with track and cross country. But aesthetic sports, I think we just really need more focus on, kind of like that dance and that gymnastics. Anything of that nature, diving.
Horseback riding.
Oh my goodness. Wrestling.
Football.
Oh man, that stuff, you're recommending some actual eating disorder behaviors, right? But I think there needs to be greater assessment there. And I reflect on my own time, and I think I might have answered this one sheet that was like, have you ever thought poorly about your body? And again, we have to remember these are the most secretive disorders you can have. I wasn't going to be like, now that they mention it, yes.
Now's the time to tell
right? So people will be like, well, we assess. And I'm like, oh no, we need to do an actual cognitive assessment, a whole systems assessment, look at risk factors, and then ask again. I think that's a huge thing. Sometimes asking one more time, right? Are you sure there's not anything else going on? It makes people feel like they care enough to actually truly invest. They didn't ask one time. They want to know. But those are some risk factors that I definitely see. Obviously, if there's a history within families and things of that nature, if they've actually, been exposed to an excessive amount of diet talk, right? So again, that can be in the sports. It can also be in families, right? There's really damaging sentences. It can be like Thanksgiving, right? And at least somebody in the family's got to say, I got to run all this off tomorrow.
Or can't eat all day because I'm eating later.
Oh my goodness. I'm like, you just talked about restricting all day to binge at night, right? And then you said you're going to purge and compensate by actually running it off tomorrow. And that's like normalized.
Totally.
So those are some things too, that if there are, certain familial things that are going on where a lot of weight and shape and body is a priority, I view that as a pretty significant risk factor. Are there some other things that you've seen in the field that you've kind of made some connections with?
Absolutely. So my specialization in trauma, I see a ton of connection between post-traumatic experiences and eating disorders. Sometimes the eating disorder comes first, and sometimes it comes after. So I don't do a lot of work with children. Majority of my caseload is like 16 and up. So I see what it looks like in adulthood after children hear these things, experience trauma, because 90% of the world experiences trauma. So everyone is experiencing trauma. Some people develop PTSD, some people develop an eating disorder, some people develop both, some people develop OCD, some people develop major depressive disorder. So what determines what someone might develop after a traumatic experience is going to be contingent on those comments.
Right.
So if we want people to be resilient in the wake of trauma, we have to be conscious of what we're saying to them, because that might be the catalyst of an eating disorder that lasts lifelong, and honestly sometimes lasts even longer than the healing of the trauma.
Absolutely.
So I see those two connected all the time.
Yeah, and that's where there's kind of this saying of what started the eating disorder isn't what's always maintaining it. Right? So maybe the traumatic event triggered it, but it'll stay much longer through those PTSD symptoms that have lessened, right? And what people don't realize is anorexia specifically, but a lot of eating disorders, they are anxiolytic in nature. Meaning they actually work somewhat like an anxiety medication.
Calm you down, yeah.
And they work, right? Because, that doesn't hurt so bad, I can't even feel.
Yeah.
And I think that's such a challenging, people be like, how will they harm themselves in this way? I'm like, oh no, they're protecting themselves, you guys. And, but like you said, if somebody has that predisposing factor of undergoing a traumatic event, right? Especially during formative years, it could literally be, I could say, honestly, I'll bet one sentence could trigger which way somebody's going to go, right? Could I go a healing path, or do I go, oh, that would help, right? I can't take away my trauma, but I can take away this extra weight. Right. I can't take away my trauma, but I can numb this anxiety down a little bit more, right? And those are just huge risk factors that I see come through. And the comorbidities. Eating disorders rarely show up alone, right? And so that's the other thing, though, that clinicians need to be assessing for is we do have to do a full systems approach, right? Especially things like OCD that can really mimic things along the nature of ARFID, right? Another eating disorder a lot of people don't even know about. Sometimes you can have an eating disorder without having heavy concern about your weight or shape or size.
Pica, absolutely.
Absolutely. And so those are those things as well that we just need more awareness in there.
The wild thing, even as an eating disorder specialist, and I've been studying this for 10 years, I don't really know that much about the other types of eating disorders. So I have experience working with ARFID. I have no experience working with pica. So even within that umbrella of an eating disorder or of eating disorder diagnoses, the spigots of the different disorders are incredibly different. The presentation of someone with anorexia looks entirely different than the presentation with someone with bulimia and binge eating and pica and ARFID. So it shows how complex being an eating disorder provider is and how many different hats you have to wear.
Right. And, I love like your authenticity and your transparency of, I don't have that sort of experience. And another one I think of for me that I have very minimal experience working with is rumination disorder.
Never.
People don't even know that it exists, and it happens.
I forgot about it.
Yeah, right. See, and that's what's so challenging is, I think I mentioned something of that nature to another clinician or something, and they're like, oh, when you think a lot. They didn't even know that, you know what I mean? That can be the, purposeful or not purposeful regurgitation of food.
Yes.
But these are excellent providers in the field of what they do. They didn't even know this diagnosis existed. And, I think that comes back down to that training again of like, maybe you had one question on a test and what was it about? Anorexia. Yeah. Right. Yeah. But those are the things too that we've just got to be assessing for the crossover between, is our depression actually functioning are we slowly trying to kill ourselves? And I know that's so abrupt, and we're trying to, this is such an upbeat and fulfilling conversation.
It's a slow suicide though.
It is a slow suicide. And that's what people don't always realize is that, you don't have to technically make the quick decision, but that's where the end goal is. The end goal of an eating disorder, specifically anorexia as well, is to kill you. Yeah. Right? And that's the severity of these things. So when we say you need to see a specialist, it's because the motivation of these disorders are to kill the individual.
Well, they're the most lethal mental health disorder.
Right. And so you're telling me that only 0.01% of us can accommodate it? That's so challenging, right? And even like we said earlier, we will be growing every day, continuing our education, challenging ourselves to become better clinicians. But how is the most deadly disorder, following things like opioid
it actually,
overdose?
It's back on top.
Oh my goodness. So that's always close. But here's the parallel. Opioid, or overdose, things of that nature, everybody knows about. They're like bad, prevent, help, people are giving out Narcan or things of that nature. And I'm like, okay, hold on, wait a minute. There's a lot of addiction specialists. I don't know about you, but there's a lot of rehabs in my area, detox facilities.
And accessible to care.
Accessible.
And covered by insurance.
Absolutely. And insurance doesn't cut you the day that you're sober. Yeah. They let you stay.
Whereas once you hit your weight goal.
Oh, weight goal? She's good, right? They're good. But I think that's just so challenging that, this is the most deadly disorder. And 0.01% of us. Yeah.
So listen to these stats. So 0.01% of therapists specialize in eating disorders. 9% of the United States struggles with an eating disorder. So proportionally, I don't know about you, but people are knocking down my door because they're like, I need this help. And because there's not enough of us. No. So we need more providers and more people educated. So that's why I've started this training program for fitness professionals.
Yes. Oh, tell me more about that. Yes.
So I provide this 3-hour training on how to spot the risk factors of an eating disorder, what it might look like coming into your studio, your fitness center, and learn how to have the conversation, give them resources of how to refer out, ways to be part of the treatment team, because I have seen so many fitness professionals say damaging things. So we want them to be part of, because fitness and exercise is a massive part of recovery too.
Absolutely.
So we want them to be part of the team.
Well, just discussing too, that a treatment team actually doesn't just have to be those sort of professional, specialized providers, right? So yeah, if we're going back to like the athletes or the fitness professionals, as you're stating, if you are working with an athlete, we need the coach involved.
Yes.
Right? We probably need the athletic trainer, depending on what circumstance we're in. But again, those individuals also need to be aware of what's going on and why, so that those damaging comments aren't directly working against the work we're trying to do with our clients. But that, again, just we're trying to hone in on that treatment team, right? And you even said, people are like knocking down your door, and they are for me as well. And, I talk to other providers near my area. There's a whopping not a lot of us here that are actually specifically, specialized in eating disorders. And there are times where like, hey, are you accepting clients? Nope. Are you accepting clients? And it's the saddest thing to answer. I'm sorry about this wait list. I can't confirm when this could occur, but how sad that I can't be like, who's wonderful, right?
Yeah.
So luckily, again, online does make certain changes, but especially with certain acuities of eating disorders, online can be very helpful. And also sometimes I believe that it can be contraindicated. Yeah. If there are certain severity symptoms, we need to be able to look at things. There are certain symptoms, hands, discoloration, things that nature of Raynaud's, looking for even maybe any signs of, relating to purging. If that's something, if they're using a method of a hand, we need to look at their ability to stand up quickly, sit down. How are they walking into my office? How did they present today? Do they seem disheveled? Do they seem energized?
Even the way they take up space on the couch.
Absolutely.
So I have this one client who, when we started treatment, it was like, and I just was so drawn to this experience, because as we started exploring the eating disorder, and then one day, spread out on the couch.
Wow.
So
that's cool.
Yeah.
That's
so
great.
You're right. Yes, it's amazing that we have virtual services, and there's so many things that are communicated in person as well. There are 0.01% of providers that are eating disorder specialists, and if we can inform so many other people, it'll make the lives of so many people improve.
Right. And the thing is, we want to share, right? And we don't want to gatekeep this information. Yeah. However, behind the gates, there's a lot of information to learn. Yeah. And I think that's daunting for people, right? We're talking about 10 years of experience and things of that nature to get to where we are today. We're going to continue growing for years and years and years. That can be really daunting to come against. And I think that's what I've seen with some other clinicians. They're like, where do I even start? Yeah. They'll maybe even hear me use certain language of behaviors or things of that nature. And it almost scares them. And so I really would love to see that change in there. And I almost want to tell another clinician, this work is so rewarding and you can do it. And you will learn a lot from your clients and you will teach your clients so much, right? But this field, it is so special and so near and dear to my heart. And I want people to know that you can do this, and there are people that would actually love to help you get to this state. Will it take some hard work? Absolutely. But will it be worth it? Absolutely.
What makes this work so important to me is having colleagues to talk to about these sort of things. My friends in grad school, I constantly am like, hey, what's going on? Having colleagues through being a provider in a field like this is so important. Yes. I would love to know what it's like working with me.
So working with you has actually been really awesome, because we both have our own histories, like we were discussing, one interpersonal, one intrapersonal, right? But you have this nuance into what you do and why. So obviously you're very good at what you do, the way your brain works. I love when we pick each other's brains there. But you can pick up on certain nuances and mechanisms that's truly so impressive. And it's challenged me as a clinician, right? So there are times that after we meet together, I will actually approach a session the next day differently, right? And that's been something that's been so cool. The connection, like you were stating, is just so important, right? And having this, we're going to need support from time to time. We might even need some accountability.
Yes.
Like, hey, Zoe, what's our schedule looking like? Where's our break? So those are things that I'm very grateful for. And I'm just really looking forward to us continuing to learn more together, grow together, whatever happens in the future for us. But it's truly kind of been a pleasure. I'm really, really grateful. We both went up to ask questions after the same lecture. I think it's a really kind of poetic way of meeting, and the way things have just hit off has just been so awesome. And that's even rewarding too. It's like when you talk about what's rewarding with clients, but even just with other providers, when we have breakthrough moments together, those are professional moments that are just so cool, right? So my heart has a lot of gratitude for you. I really just feel like this is something that's been so special, and I just look forward to our future together.
Me too.
You amaze me. And
so many goals and dreams.
We have so many goals and dreams, and we're starting here together, right?
Yeah.
For people that could be watching this, we've got a nice little Google Doc of Maria and Zoe ideas of I just love that you have the same drive, right? We want to make an impact, and you're making an impact if you just meet with clients, right? Being a provider in this field, you're making an impact, but I love that we both just want to challenge each other to be like, what other things can we do here, right? How can we use our skills and expertise to truly make a difference in multiple facets?
Yeah.
Right. Yeah. So I'm appreciative of your help always, of your guidance, and also just our camaraderie. Yeah. Right. Sometimes it's, hey, let's collaborate. And sometimes it's, how was your weekend? Yeah. And that's such a wonderful balance that I think we get to eloquently then practice with one another.
Just being humans together.
Yes. Being humans.
And I think that even mirrors the work that you do within eating disorders. Yes, this is a part of you, and let's learn so much more about you. So I love the parallels between them.
Yes, it's our clients are not walking eating disorders. Right. They are humans. They happen to struggle with an eating disorder, right? That's kind of another language that would get down a rabbit hole of somebody saying, I am an alcoholic versus, I struggle with an eating disorder. And that's a story for another time, but it is important to remember that I do like that idea of you are a human first. You are not a walking eating disorder that came into my office and naming those. But it's kind of like us. We are not just an eating disorder provider.
Yeah, we're people.
Yeah, we are humans, and our stories to get here are just as impactful. Yeah. And we happen to be eating disorder clinicians.
Right.
Right. And I'm grateful every day I get to say that sentence.
Me too.
Right. So it's very cool to be able to share that with you.
You as well. So what would you say is the most rewarding part of this work?
I kind of mentioned earlier that when a client starts to see hope, oh, it's really cool. Or when almost you get to meet your client for the first time, kind of how you described, right? When you described the client kind of really sunken back in the couch, and then they're just sprawled out, kicking their shoes off. When you start to see that personality shine through, and you start to see, when clients are like, oh my gosh, I never thought I'd get this far. And I'm like, right. And actually don't limit yourself here. Yeah. Right. But that's always just a really cool moment when people surprise themselves. People are taking a huge risk when you choose to engage with recovery. And yes, you do have to make a choice, right? Yeah. It's a huge risk. You are risking on giving up that sense of safety and comfort and things of that nature. But when people see that risk paid off, it just makes the story look so beautiful. Right. And so I think that's probably the most rewarding thing. Especially if maybe you've worked with a client for a decent amount of time and you saw where they started, and then you have a discharge session and you feel wonderful about it and you're excited for them. It kind of gives me chills, right? But that's stuff I wish more people could see. There's a reason this job is so rewarding, and it's because so many people do recover. Right. And even those that continue to challenge or things of that nature, it's still rewarding work when how can we improve your quality of life, right? All right, we're struggling with making these changes. How can I help you just today then, right? Let's not face the whole mountain, right? Let's just face a little step. Even if we side forward step, what can we do? And finding those intentional changes is just really cool. But what would you say is the most rewarding part of our job?
Oh gosh. I mean, I echo all of those statements.
Yeah.
There's something so gratifying about having a job that wants you to fire them. Because right,
oh my goodness,
I was like, I want you to leave my life.
I love looking at it like that. Yes.
So having it's very complex, and I miss my clients that terminate and move on in the world, and also it's so beautiful. But I think for me, as we were talking about, the eating disorder serves so many functions, and I love when my clients don't feel like they need to change themselves, and can still use all of those things that kind of created the eating disorder, the sensitivity, the compassion, the openness, the self-understanding, and we can shift it to something pro-social and healthy. So not changing who they are, just kind of changing their reaction to these experiences. So that for me is so rewarding because they themselves there's nothing wrong with them. Right. We just need to figure out a way to change these behaviors. Right. And finding love for yourself away from those behaviors into something rewarding and beneficial. So I love seeing how they interact with their own identity in a different, more happy and healthy way.
Right. You know, and I think too, because I don't know who will even really have eyes on our conversation here.
Yeah.
I hope there's obviously some clinicians that can watch and learn some things from this, but I also hope if there's anybody out there that strolls across this, that struggles in their own way, we're talking about what's rewarding to watch this occur. I can't even describe to you what it's like to be the one that has that occur. And I want people to hear that, because if we're just watching somebody, their life change, it's so impactful. I want people to hear that this is something that can happen for you too.
Yeah.
Right. And that the rewarding piece, it'll keep giving the rest of your life. Right. So I think that's something out there that I hope that people can listen to and believe in themselves one day. I know there was somebody that spoke at the conference that we went to together that talked about holding hope for clients. And letting people know I really hold hope for each of my clients. And sometimes I'll even ask, can you hold any right now? And sometimes they'll be like, I don't know, a little bit. And sometimes I'm like, you know what? I can hold it for now then.
Right. I got you.
Right? I'll hold it right there. And someday let's share it.
Yeah.
And by the end, they've got it. Right? So I just think that's an awesome progression too that I had to have shared there.
I love that so much. Thank you so much for being here.
Yes. Thank you so much for having me. I appreciate it.
Special thank you to our advertisers, Alsana. Alsana has both physical locations in Alabama and California, and then virtual IOP. They also have an IOP specialized for teenagers, which is really, really cool as well.